Okay, I'm gonna go ahead and get our CME stuff out of the way so I can give her a proper introduction. So for those of you who are claiming CME credit, I'm gonna give some information about that, but we just want to let you know that we are partnered with the TAFP for this presentation. And then you can see our department mission statement there. As we go ahead and begin, if those who are on Zoom, if you could just make sure that your microphone is muted, and then of course, everyone, if you could remain engaged in the session as Dr. Bazaldua is presenting. Also, I will email everybody an evaluation link if you can help us with providing some feedback. But for those who are claiming credit, please make sure that you do so before midnight tonight. The code is listed here for you. And in this next slide here, you can see if you have not yet registered, just send your email address to the number listed there, the toll-free number. Once you've done that successfully, you can then text attend, and then the code for today is listed there. But I am available if anybody has any questions or concerns with that. For those who have claimed credit, make sure that you do check every so often that you are getting your credits. You can do that by visiting the CME website. But if you have questions, please reach out to me. Also, those who are members of the AAFP, you can claim credit through their system as well. So keep that in mind. And we also just want to make sure that we mentioned that it is our goal to meet these nationally established physician core competencies through these presentations. So you can see those listed here. And then we do need to mention that Dr. Bazaldua has no financial relationships with ineligible companies to disclose. And Dr. Bazaldua is a PharmD faculty for the Department of Family and Community Medicine, the Director of Departmental Pharmacy Education, and Director of the Pharmacotherapy Clinic. She has a passion for teaching appropriate medication use to both providers and patients. She has expertise in health literacy and medication use and has presented extensively on this topic. Her mission is to collaborate and lead the improvement of appropriate medication use in ambulatory care settings. She is actively involved in local community organizations and international research groups. With the current needs in healthcare reform, she is also actively involved in quality improvement initiatives, especially as they relate to medication reconciliation and the prevention of medication-related errors. So I would like to give this over to Dr. Bazaldua. She's going to present to us therapy updates in type 2 diabetes.
Thank you, Nicole. All right, so I know some of you are still eating, but I'd like to make this as interactive as possible. So you will need your phone for this. So I have this new program here. It's called Slido. So if you do the QR code and answer the question. Anyone else? All right. I know we're running behind, so I'm going to go ahead and move forward. Some say daily, some say weekly. And there will be some questions like this throughout the presentation, so keep your phones handy. The website should be kept open there on your phone. All right, so what I'd like to do today is summarize some of the new drugs that have become available since I was here last year. And then we'll discuss the summary of the revisions in the standards of medical care in diabetes. And review patient cases at the end and try and put some of these new updates into practice. So these are the new drugs that have been FDA approved recently within the last year or so, year and a half perhaps. So Wegovy is one. It's called semaglutide, which is the same ingredient as Ozempic. Lyumjev, it's Lispro, and this is a biologic. Semglee is glargine. It's a glargine long-acting insulin option. Mounjaro, I'm sure you guys have heard about this. It's a new medication for diabetes, but people are using it for weight loss. And then Kerendia is another medication that has been FDA approved recently. We'll talk about that briefly. The generic name is Finerenone. So just to kind of give you a reminder about the drug classes for diabetes. So of course, we have metformin that for years we have considered this the first drug for patients with type 2 diabetes. We'll talk a little bit about that update. And then the SGLT2 inhibitors, canagliflozin, dapagliflozin, and empagliflozin are the 3 drugs that we will be using most of the time because those are the ones with the most data. The GLP-1 receptor agonist, there's Victoza, which is liraglutide. And just to point out, there is a Saxenda, a 3 milligram dose, which is FDA approved for weight loss. The Victoza is for type 2 diabetes. And so Wegovy is a once weekly GLP-1 receptor agonist. And then Mounjaro is a new class of drugs because it doesn't only activate the GLP-1, but also the GIP. And then you have the DPP4 inhibitors, the TZDs, and the sulfonylurea. So I just kind of wanted to give you kind of a big picture of where these drugs fall into place. So remember these drugs, the Invokana, Farxiga, and Jardiance, the 3 SGLT2 inhibitors. The 2 drugs are insulins. Again, there's a rapid acting, which is Vyumjev. It's a biosimilar, and Semglee is a long acting. So in case Lantus, for example, may not be on the patient's formulary, you might find that maybe Semglee is, and it's a biosimilar to Glargine. All right, and then Kerendia is the other drug that I told you guys about. So Kerendia is finerenone, and it is similar but different to spironolactone and eplerenone. And it basically has a difference in terms of selectivity and tissue distribution. So Kerendia and finerenone are the same drug. Kerendia is a brand name. So Wegovy, I just wanted to touch a little bit about Wegovy. So again, it's the same thing as Ozempic, but it's a higher dose. Ozempic goes up to a dose of 2 milligrams, and Wegovy was FDA approved at a dose of 2.4 milligrams. So Wegovy is FDA approved for weight loss. The Ozempic is not, it's only FDA approved for type 2 diabetes. And I just kind of was, I'm sharing here on the slide the studies that got this drug approved. And so I don't have all the data here for you, but the 3 studies basically showed that a baseline weight of usually, so the first study is 105 kilograms. Study 2 was about 99 to 100 kilos. And then study 3 was about 106, 107 kilos. So the change from baseline was 14.9 for the first study, 9.6 for the second, and then 16 for the third study. So again, pretty significant weight loss. And compared to placebo, there was a statistically significant difference. So that's all I'll say about Wegovy. Mounjaro, again, you'll probably have patients asking you for it. I know we had clinic this morning and a patient came and asked about that. She wanted to use Mounjaro. So again, like I said earlier, Mounjaro activates both the GLP-1 and the GIP. So it's a new class of drugs. And what this does is basically it decreases, and I'll go through the picture there. It decreases the food intake, so patients are not as hungry. It also slows down the gastric emptying. So that's why if you have patients with gastroparesis, it's probably not a good option for these patients, just like neither of the other GLP-1 receptor agonists. It also reduces the glucagon levels. It is good for patients to increase the insulin sensitivity, and it also enhances the insulin secretion from the pancreas. So basically this drug, again, is not FDA approved for weight loss, it's for type 2 diabetes. There is, from what I read, a fast process to get this approved for weight loss, but as far as I know, it's not approved just yet. Some of the limitations or contraindications, according to some of the studies, are that pancreatitis. If a patient has pancreatitis, they should not be using it. Again, if they have gastroparesis, I think a lot of times we have gastroparesis that's probably undiagnosed. So if the patient is not really tolerating it very well, you might find that maybe they had gastroparesis that we missed initially. If they have MENS 2, it's also contraindicated. If they have any allergy to this medication. This is a big one, thyroid cancer. And remember to ask if the patient has a history of thyroid cancer themselves, and specifically medullary thyroid cancer. Okay, The other question to ask, if you don't, how about any family members, any immediate family members with a history of medullary thyroid cancer? Okay, that's important. And it wasn't studied in patients with type 1 diabetes. So probably not good to be using in those patients. So it comes like this. It's 1 dose per pen, and it's dosed once a week. So it's got 6 levels of dosing increases. So starting from 2.5 up by 2.5 milligram increments up to the maximum dose of 15 milligrams. And some of my students are here with me, and I asked them to bring a sample. And you guys, I know when there's one there, you can pass it around if you guys want to see what it looks like. But it's a 3-step process for using this injection, so it's very easy. So you unlock it from the green to red, you take off the cap, you inject, and you throw that away. You're done. 3-step process, pretty simple. It's important to remember that because it does have side effects like nausea, vomiting, that we should start low and increase the dose. And the recommendation is that we increase it every 4 weeks. Okay, and you go from 2.5 in 4 weeks, you go to 5, and in 4 weeks, you go to the next one. And I also get questions a lot about, well, what if I miss my dose? I usually take it on Sunday, and what do I do if I miss it? So the general recommendation is, for Mounjaro at least, if it's 4 days or less before your next dose is due, you can go ahead and take it. But it's longer than 4 days, then just skip it and take the next dose. Okay. It does need to be refrigerated. Okay. I know I had a patient on Trulicity, and we forgot to tell her, or him, I forgot the patient, to actually refrigerate it. And that's a very expensive drug to not use. It is, for example, it is good out of the fridge for about 21 days. So if the patient has to travel, then that should be hopefully not an issue for them. So sometimes they pack a big ice chest, and they go through all this whole thing about keeping the drugs refrigerated, but it's not necessarily needed. So it's good out of the fridge for 21 days. And if there at any point you have any questions, please just raise your hand, or I think you can type it into that Slido question. What is the cost? An arm and a leg. So if you're paying cash price, which hardly anyone would probably do that, but it's anywhere between $900 and $1,000 a month. So it's pretty expensive. Yeah. So a little bit about the effectiveness. So again, it is indicated for patients with diabetes type 2. So the average A1C decrease is about 1.7 on the different studies. The weight loss on at least according to the package insert, was about 7.8 kilos. Common side effects very similar to the other GLP-1 receptor agonists. So nausea, vomiting, diarrhea. Some patients get constipation. I always tell patients that they will probably see a decreased appetite, especially for the little old ladies that the family wants them to eat. I tell them it's okay. This is what it's supposed to be doing, decreasing the patient's appetite. Some patients have some abdominal pain as well. Questions on this? Now, the other question is, well, how does it compare to the other drugs for that are in the similar category? So they did study it against Ozempic. And who remembers what the maximum dose of Ozempic is? 2 milligrams, 2 milligrams. Yes, so they studied it with a 1 milligram dose. So it's not exactly apples to apples, right? So it's might be a little deceiving. But the Mounjaro, the 15 milligram dose, if you look at the change of A1C decrease, it went down to by 2.3. The 10 milligrams is 2.2, and the 5 milligrams 2, which is actually pretty significant, almost similar to the metformin levels that we see. In terms of the weight loss, at 40 weeks, the semaglutide was about 5.7 down in kilograms. And then the Mounjaro dose from 5, 10, and 15, the effectiveness was higher as the dose was higher. Okay. And remember also that the side effects can also be dose dependent. All right, pull out your phones. Here's another question. So how often should the dose of Mounjaro be increased or titrated? If you start at the lowest dose, how long do you have to wait before you go up to the next dose? So it's dosed once a week, but if you start at 2.5 milligrams, you wait 4 weeks, then you titrate it to the next week. So really 4 weeks is the intended answer here, but it might be confusing for the dosing once a week. All right, so Kerendia, this is Finerenone. I won't say much, well, I have a couple of slides on this, but I wanted you to focus on the red box down there. So it's approved based on 2 of these studies, which the first one is Fidelio DKD, and the other one is Figaro DKD. And basically they looked at kidney outcomes as well as cardiovascular outcomes. And as you can see, all the hazard ratios were less than 1. So a pretty effective drug. So basically they found that patients on this medication had prolonged time to dialysis, renal death, and even cardiovascular outcomes. So it's used to treat patients that have CKD in patients with type 2 diabetes, and essentially to reduce the risk of worsening of kidney disease, kidney failure, death due to cardiovascular disease, heart attack, hospitalization for heart failure. So it has improved all these indications here. It's contraindicated in patients with strong CYP3A4 inhibitors. So there's a list of drugs there. I didn't write these down here. Patients with adrenal insufficiency should not use this drug. And then it was not listed as a contraindication, but I would consider a contraindication if patient has high potassium, okay, because it can increase the potassium, just like spironolactone. So we have to make sure we look at the baseline potassium level and then monitor it after that. So side effects, hyperkalemia, again, hypotension, and they can also get hyponatremia. And the dose is either 10 or 20 milligrams, depending on the patient's GFR. Again, because they can cause hyperkalemia, you don't want to start it in patients with a GFR less than 25, because that can get worse. Question, yes. So the question is, if you have a patient with a GFR of 25 and 60, the table here says start once daily. The question is, can you go up to 20? And I haven't used this drug, actually. I do have a patient that I'm thinking that she might be a good candidate. But as far as I know, you stay at the 10 milligram dose. All right, and then if you have patients that have hyperkalemia, there's a table here to kind of guide you in terms of how to adjust that. But I also have here on this slide the KDIGO recommendations. And so I'll just basically, they say that we suggest a non-steroidal mineralocorticoid receptor antagonist. So the spironolactone is the steroidal MRA. This is the non-steroidal. So basically they're talking about Finerenone, okay? One that has proven cardiovascular benefit. Patients have to have an eGFR greater than 25. Their potassium should be normal. And they should have albuminuria greater than 30 milligrams per grams. Okay, and this is in patients that are already on a RAS inhibitor. All right, another question. What is a side effect of Kerendia or Finerenone that needs to be closely monitored? Excellent. Hyperkalemia is correct. So now I'd like to move over to share this consensus report between the ADA and the European Association. And basically it's hot off the press. It just was published recently in the last few weeks. And basically they have a focus of more on social determinants of health, the overall healthcare system, and physical activity behaviors, including sleep. So they're not talking about just use these drugs to treat diabetes, but they're using a more holistic, comprehensive approach. And they have a bigger emphasis on weight management. And they have broader recommendations for the SGLT2s and GLP-1 receptor agonists that I'll share with you in a few minutes. Before I discuss some of these new recommendations, I wanted to maybe brag a little bit about our team in the UT Health Science Center and the Family and Community Medicine team that was led by Dr. Robert Ferrer. This was just published, when was this? Just like maybe a month ago, I believe. But the title of this is Community Health Workers as Trust Builders and Healers. It's a cohort study in primary care. So basically, it's a team of promotoras and some of our faculty that put this project together. And basically, we're highlighting the work that our community health workers do. And the purpose was to evaluate whether a practice integrated community health worker intervention could encourage effective long-term self-management of type 2 diabetes. So can our community health workers help our patients manage their type 2 diabetes? And so they engage patients, I think it's almost nearly about 1,000 patients, and they categorize them into 3 groups. One group was they just did an outreach. So the duration was 1 to 7 weeks. The second group, they did a stabilization. So they built trust and they created an alliance or a team in terms of addressing barriers to their care that lasted up to 12 weeks. And the third group was self-care, what they call self-care generativity, kind of a hard word to say. But they actually encouraged the patient, and they were up to 12 weeks, they encouraged the patient to actually take ownership for their self-care. And they looked at the A1C over time, and they looked at this over 4 years. And what that graph shows here in the orange, the third group, the self-care generativity, basically these were the patients that were more engaged, and they had a larger decrease in A1C. And it's not like the Yujasan Munjaro of 2 point something. It was modest, I believe, like between 0.3 and 0.4-ish or so, but that is clinically significant. Some drugs get approved for that level of effect on the A1C. So the conclusion of our colleagues' authors is that community health workers helps 32% of patients attain a behaviorally defined level of self-management that was named self-generativity. And this was associated with sustained clinically meaningful reductions in A1C for up to 4 years. And also a decrease in the risk of emergency department visits and hospitalization. So again, this goes in line with the new recommendations of taking diabetes as a holistic approach and looking at the social determinants of health. All right, so now to review some of the recommendations from this consensus report between the ADA and the European Association. So one of the first things that I just highlighted things that I thought were important that I learned from as well, that I thought you might be interested in learning. So one of the first things that I read is that the greatest absolute risk reduction comes from improving very elevated glycemic levels, okay? And a more modest reduction results from near normalization of plasma glucose levels. So the way I read that information is that the patient with the higher A1Cs will have the biggest benefits. Okay, so if I have a patient with an A1C of 16 and I get them down to 9, they might get a better benefit than a patient has an A1C of 8 and I get them down to 7. That's the way I read that. So I think that might be important. And those of us doing perhaps population management. So there's evidence that patient education or diabetes self-management education and support that is actually useful. It significantly improves several things. Of course, knowledge you would expect, glycemic levels, but it also improves clinical outcomes as well as psychological outcomes. And the other nice thing that the evidence showed is that it reduced hospital admissions, all-cause mortality, and it was cost-effective. So patient education is actually very, we have evidence that it's useful. Glucose monitoring. I always get this question too. My patient doesn't want to check their glucose levels because it hurts. And when I look at their medication list, they're not on insulin. So the question is, should they be checking their glucose levels or monitoring? So they're suggesting that if they're not on insulin, then the routine monitoring is of limited clinical benefit. And it's only going to add more burden to the patient and more cost. So they're basically giving us permission to not really use it if we don't need it in some of the patients. But they also suggest that in some patients, it might give them some feedback, some insight. And for example, it might tell us that this cake here might increase our sugars more than the salad, right? So it might give them some insight so that they can learn about their disease state. Physical activity, I thought this was really interesting. So what the data shows is that an increase of 500 steps per day is associated with 2 to 9% decreased risk of cardiovascular morbidity and all-cause mortality. Who knew that? No, I didn't. I mean, 500 steps. I actually counted yesterday from my office to my car. It was 250. So round trip is 500. So that's nothing. But this is in addition to what we are already doing. So I think this is I guess encouraging that we can tell our patients you don't have to exercise, 2 hours a day to get some benefit. Even just increasing the number of steps to 500 per day will give you some benefit. And then I want to share with you what they talk about in terms of the SGLT2 inhibitors and GLP-1 agonists. But I just wanted to just show you, I'm not going to go through all these tables, but these are the studies that have been done in SGLT2 inhibitors. So this here is evidence supporting the use of these drugs to delay the progression of CKD in patients with diabetes and kidney disease. So there's the Canvas program, Declare TIMI 58, the EMPA-REG, and Credence. So looking at or using those drugs that we talked about earlier, Nagliflozin, Dapagliflozin, and Pagliflozin. And I don't have the numbers needed to treat here, but they're anywhere between 19 and 23 in some of these studies. So it's very significant. So I just circled for you at the bottom, the hazard ratios, they're all less than 1. So very effective. So again, evidence supporting the use of these drugs in basically the progression of CKD. These drugs also have been used in patients that don't have diabetes, and they found benefit on that. So what this tells us is that even if they don't have diabetes, they can get benefit from this. Okay. These trials looked at these drugs in patients with heart failure. Initially, we thought they were just useful in patients that have a reduced ejection fraction, but they also found benefit in patients with preserved ejection fraction. So these trials are giving us evidence that we can use this in patients with either reduced or preserved ejection fraction. So based on all this data, the consensus report has these recommendations that I like to share here with you. First one is, if you have a patient with CKD, and this is key. Last time I was here last year, I said the eGFR has to be greater than 30. That has now changed. So this is one of the updates. The eGFR can be down to 20. So it has to be 20 or higher, okay, before you can use these drugs. So if they have CKD with an eGFR greater than 20, you can use these SGLT2 inhibitors. If you have a patient with heart failure, also we can use one of these SGLT2 inhibitors to prevent the major cardiovascular outcomes as well as mortality. So the third recommendation I highlighted there in yellow. So this one I think is really more practice changing for me. So this is in individuals without established cardiovascular disease, but they have multiple cardiovascular risk factors. And they include patients age greater than 55, they have dyslipidemia, albuminuria, smoking, hypertension, and/or obesity. And I like the acronym, so that spells DASHO, D-A-S-H-O, for easy remembering. So they're suggesting that these patients have these risk factors, that you can use a GLP-1 receptor agonist with proven benefits, or you can use an SGLT2 inhibitor. Okay, so the first group, they have CKD, second group has heart failure, this group has extra risk factors, okay? And the two bottom points are also key. This is independent of whether they are on metformin or not, okay? So before we used to say, oh, they should be on metformin first, right? I always got the question, in treating diabetes, I know that metformin is first line. What do I do next? So that's not necessarily the case anymore. I think metformin is still, should be first line for a lot of patients because it's inexpensive and safe, and we have lots of data. But this is independent of whether they are on metformin and also independent of whether they have an elevated A1C. Okay. Question, yes, ma'am. So the question is, are insurers going to cover for these patients in the yellow category? And the answer is, I don't know. I don't know. Yeah, I guess we'll find out. But in terms of the insurance, and these drugs are expensive. The SGLT2 inhibitors, if you're paying cash price, they cost about $600. The Mounjaro we talked about, $900 to $1,000, right? But if you think about what they are actually doing, right? So they're actually preventing the development of dialysis or delaying the progression, renal death, cardiovascular outcomes, mortality. And I think what we need more data on is cost effectiveness of these medications. I did a little bit of search and I found some some studies that say they are very cost effective, but I don't have any of that data. I didn't really look at it extensively to really share a lot of that with you. All right, this is a personal question. How many hours of sleep did you get last night? There is a point. There's a teaching point on this question. Less than 6 hours is winning. 6 to 8, only 31%. 8 to 10 hours. All right, so this is why I'm asking, okay? This is also part of the consensus report. So what they suggest is that sleep is associated in a U-shaped manner with health outcomes. So longer than 8 hours and less than 6 hours is associated with negative impact. So those of you, so I think there's only 31% of us that actually slept within 6 to 8 hours. And most of us slept less than 6. So we need to increase our sleep duration. I know I was one of those in the less than 6 hour category, so I know that's not good. But actually, I don't usually talk to my patients about sleep, but this is actually helpful in terms of making sure patients we always talk about diet and exercise, and also sleep is also important, okay? Weight loss medications are effective adjuncts. I had a question, I did a trial run with some of my students. One of the questions they had is, well, if I use the Ozempic, the Mounjaro, these other GLP-1 receptor agonists for weight loss, will they gain the weight back? And this actually answered that question. Withdrawing treatment with semaglutide leads to increases in body weight. And I think this is probably expected, right? Just like any other medication, I had a patient earlier that stopped taking their lisinopril for their blood pressure. Guess what happened to their blood pressure? It went up, right? So the same thing with weight. So you have a drug that decreases the weight, you stop taking it, the weight's gonna go up. And the second part there is just sharing the same thing that I shared with you earlier about using GLP-1s and SGLT2 inhibitors. So for the sake of time, I'm gonna move on. And this is just some slides that I cut out from the KDIGO guidelines. Basically, because you will probably be using more of these SGLT2 inhibitors. So I just want to make sure that we have some take-home messages from this. The main thing is make sure that the patient has a GFR greater than 20. And I think that we should probably be more intentional about starting these agents in patients. So having a team looking at the patient's chart, do they have CKD? Do they have heart failure? Do they have any of these risk factors? Are they on any of these drugs? Because I think the outcomes are so beneficial. Let's see, potential contraindications for these drugs. Because of the way they work, the SGLT2 inhibitors can increase the risk of genital yeast infections. And so we always want to tell the patients about document or watching for that, okay? I always tell the patients if it happens, we can always treat it. And I really want to make sure that the patients don't rob themselves of the benefit that these drugs can get, okay? And sometimes, you know, you have to think about, you know, the yeast infection versus dialysis, right? So what's easier to treat? And so sometimes you have to look at it that way. So sick day protocol under education. So these drugs, because they can cause euglycemic DKA, should be withdrawn before any significant procedure or surgery. Usually 2 to 3 days. KDIGO says 2 days. Other references say 3 days. Okay, but make sure they stop it before that procedure. Let's see, hypoglycemia, you don't really see it unless they are on other drugs like insulin or sulfonylureas. One thing that is important though is because they cause some volume depletion. If they are on other medications that cause volume depletion, you might want to adjust those so that we can prevent dehydration. And we live in Texas, so we need to make sure that our patients know to hydrate. Okay. Questions on this? This is SGLT2 inhibitors. And this is just kind of a summary. Contraindicated, they have a GFR less than 20. If they have a current yeast infection, I usually don't start these drugs. I wait till they're treated and it's gone, and then we start it. I think I always get the question, what if they have a history of yeast infection? And I always think that if they have diabetes, that the yeast infection is probably because they have uncontrolled diabetes. But I always talk to the patients about looking at how many times they got yeast infection before they started these drugs. Let's look at how many they get afterwards, and then we can make a decision. Let's see. I think we talked about the other ones already. And again, if you have any questions, just stop me as we go on. Yes, question. So the question is, can they all be started if the GFR is greater than 20, correct? Okay, so maybe the question is just make sure I'm understanding your question. So if the patient has a GFR of 30 or 40, we started because it's more than 20, right? Your question is, if it goes to less than 20, should they be continued in these patients, correct? Okay, and the answer is absolutely yes, until they get to dialysis. Okay. Yep, continue it. Now, if you're on metformin and the GFR goes to below 30, that gets stopped. These can be continued. So the key is make sure you find the patients before their GFR goes to below 20. And I would say even sooner than that, okay? Anytime you detect any CKD, we should be putting these patients on it. Elisa. So at that point, the question is, if I start the patient, well, I think the question is, so if I continue these drugs and the GFR is now down to 10 or 15, am I using it more for the cardiovascular benefit? And the answer really is because that's what the studies did. Okay. I don't know the answer specifically to your question, whether they have more benefit there or not. I don't know. I know they are actually considering these drugs in even less than 20, but the data is not there. Okay. And then some patients think they're just too many drugs, right? So this is a combination of these SGLT2 inhibitors with metformin. So Invocamet with Invokana, Zigduo with Farxiga, and then Synjardy is metformin with empagliflozin. So if these drugs are on the formulary for your patients, it's a nice combination. They are huge horse pills though, even bigger than the regular metformin. So I actually have one that my patient said, I can't swallow that. So I took one, I put it in a little index card, and I use that for my other patients. I show them, this is what it looks like. You think you can swallow it? And so that way we don't write a prescription that we're gonna be wasteful on. Let's see. And this is just a summary from the KDIGO guidelines in terms of first-line therapy for patients with CKD. And I kind of like this one better, actually, the pyramid. So I always look at diet, exercise, smoking cessation, weight management at the bottom of the pyramid. And then first-line therapy, they're saying it could be a metformin, SGLT2 inhibitors, RAS inhibitors like the ACEs or ARBs, and the statins also. And then next after that is GLP-1 receptor agonists, antiplatelet therapies, and then the non-steroidal MRA, which is the Kerendia or the Venarino. All right, let's see. We have just a few minutes. So JC is a 61-year-old male who presents today for uncontrolled diabetes. He has retinopathy, CKD, also with history of heart failure, hypertension, GERD, carpal tunnel syndrome, and OSA. He is, for his diabetes, taking Levemir 20 units twice a day and Novolog. And I won't read through the other drugs, but labs include an A1C of 12, potassium of 4.5, LDL of 50, GFR in August the 27th, it was 32, and yesterday it was 49. The blood pressure is 124/74, 116/76, measured twice. Weight is 96 kilos, and BMI is 36. So the question is, which of the following is the most appropriate oral therapy to start in JC? Metformin, 1000 BID, and empagliflozin, pioglitazone, or sitagliptin. And I have it in this slide, is here as well. What do you think? If you need to see the case again. Oh, all right. Dr. Nader says you have good memory, so no. All right. A and B is not an option, Dr. Nader. Oh, you were thinking A and B, you were thinking, okay, let's talk about that. So you were thinking A, metformin? Oh. Okay, so Synjardy is metformin with empagliflozin. Yes, exactly. Somebody is getting money from it. They beat you to it. All right, so why is metformin not the best option in this patient just yet? 1000 milligrams twice a day. Yeah, he's got a GFR of 32. And in fact, I kind of changed some of these cases around, but this patient actually, we looked at the GFR yesterday was 49, and we waited till it was stable at 45-ish or so, and then we initiated the metformin. But because he has heart failure, we said we gotta get going on that SGLT2 inhibitor. Do I agree with Dr. Nader? We can talk about that. So no, not in this case, not yet. Eventually, okay. So the pioglitazone, why not the pioglitazone? He's got a heart failure, says contraindicated. Sitagliptin, A1C of 12 is probably not going to get much from it, and it doesn't have any organ protection. Not going to protect the kidneys, not going to protect the heart that we know of. Okay. So everybody, there's a few. Yes, sir.
I'm going to ask this towards the end, but you look at the studies, and this one drug will lower the A1C X amount, and the next one will lower it some. By experience, it doesn't seem like when you give two drugs, you get X plus Y. You get some number in between, right?
Yes. So that's a comment.
What's the comment? Well,
And the question?
do you agree with that?
Do I agree with his comment? So his comment is that, the drugs are studied. For example, the Mounjaro says, if you give him 15 milligrams, the A1C is going to decrease by about 2.3 or so. Then he uses that in his patients, and it doesn't come out that way. Sometimes it's more, sometimes it's less. And yes, I agree with your comment, Dr. Nader, because every patient is individual, right? So we do shared decision-making and patient-centered care, right? Because everyone is different. So if you're my patient and Dr. K is my patient, and you follow the good diet and Dr. K does not, you get the same drug, who's going to get a better A1C decrease? Probably you, yes. And Dr. K is not. Yes. So anyway, so everyone's different, right? And so that's why you see that. Okay. All right, case number 2 is SP. She's a 51-year-old female with a history of pre-diabetes, hypertension, and heart failure, preserved ejection fraction. So she's on metoprolol, spironolactone, furosemide, and atorvastatin. Her A1C is 5.9. And potassium 3.9, LDL is 78, GFR is 72, blood pressure 119/52, weight 96, and BMI of 36. So same question, which drug would you want to start her on at this point? Finerenone 20, dapagliflozin 10, pioglitazone 30, or linagliptin 5 milligrams daily. So. So SGLT2 inhibitor, maybe the finerenone. The finerenone guys are like test takers, right? We're talking about this drug, so there's got to be an answer somewhere. All right, so we can discuss it. To be honest, I'm not sure that there's a right or wrong answer. Trick question. And, this is a fairly similar case that we saw. I think, some of my students helped me with this patient. And so we talked to her, and because she has heart failure, we decided on the dapagliflozin, okay? But before all this data, I would say, let's put her on metformin, because she has an A1C of 5.9 and she has a BMI greater than 35. The ADA suggests that if you have patients less than 60 years old with a BMI greater than 35, that maybe they need to be on metformin, even when they're at pre-diabetes, to prevent the development of diabetes, okay? She has heart failure, so she buys herself an SGLT2 inhibitor, and she also has an increased weight. So I think the GLP-1 receptor agonist would be helpful in her. What we did for her is we just did one drug for that one visit. We started her on the SGLT2 inhibitor, I forget which one, with the intention to put her on the GLP-1 receptor agonist next time, okay? Provided that her insurance is gonna cover it. So this could have been kind of going in different ways. Questions on this case? All right, case number 3. KM is a 50-year-old male with diabetes, hypertension, hyperlipidemia, OSA, COPD, anxiety. He smokes, and he has a glucometer, but when we saw him, he says, I haven't used it because I don't know how to use it. But last time I got my sugar checked, my daughter helped me with it. He's on metformin, a full dose of 1,000 BID, a Torva 80. And looking at the labs, he's got an A1C of 6.7. GFR of greater than 60, sodium 138, potassium 4.3, LDL of 162, microalbumin less than 30, so it's 8. Blood pressure is 128/77 and 132/82. Weight 112 kilos with a BMI of 43. So first question, does he really need to get his glucose checked on a regular basis? So we told him, don't worry about it, Mr. or Mrs. K, well, I guess it was a Mr. KM. And he's like, oh, good, that's easier then. I don't have to check. So the A1C is 6.7. Yes. I don't have a date on there, but let's assume it's recent, okay? So yeah, we said, don't worry about it. So usually, personally, I don't ask them to check their glucose unless they are on insulin. Because we're already asking them to watch your carbohydrates, diet, exercise, all these things. So I said, just concentrate on these things first. Concentrate on the Big Red and the Dr. Pepper, and then we can talk about, checking glucose. But some patients like, well, I like to check because I want to know that my Dr. Pepper increased by 200. So in those cases, then it's okay. All right, so what medication class would you start this patient to optimize KM's regimen? An ACE inhibitor, an SGLT2 inhibitor, a GLP-1 receptor agonist, or no change? All right, GLP-1, SGLT2, no change. So this is a patient that I think you had a question, is the insurance company gonna pay for this, right? So I went back and looked at this case, and actually this is how this would change my management, right? So this is a patient that meets at least 3 of the criteria in terms of risk factors. He has dyslipidemia. He's not quite older than 55 years old, but he does smoke. His hypertension, he's got a diagnosis of hypertension, but when we checked it, it was 128/77, not very drastic there. And he's also overweight, so obesity. So based on this information, so he doesn't have established CVD that I can see, but he has risk factors. And so those that voted for GLP-1, you're correct. And those that voted for an SGLT2 inhibitor, I think you're also good based on the evidence. And that's all I have. But there's, I see patients like this all the time, every day, so I can go on and talk about this longer than an hour. But those are the things that I thought I would share with you in terms of any updates. And there's the KDIGO guidelines are published, and it says a publication date of November. So some of this data is not even published yet that I can tell. So if you don't have any questions, I have at least 2 more other questions, I think. Oh, question. So do we give up on glipizide? Yes. Yes, so good question. Have we given up on glipizide? And at least in my practice, we hardly ever use it. That doesn't mean that it shouldn't be used because it is inexpensive and it still can be used. And I think one of the downfalls of the sulfonylureas are two, right? One is the increased risk of hypoglycemia. So if you use any of these new drugs with the sulfonylurea, the increased risk is going to go in terms of hypoglycemia. And the other downfall is that they tend to lose their effectiveness over time, right? We know that the data shows that if you have a newly diagnosed diabetic patient, you start them on a sulfonylurea because where do they work? In the beta cells, right? I know I've heard Dr. DeFranco talk about by the time you get diagnosed with diabetes, 80% of your beta cells are gone, right? And so if you only have 20%, if you're lucky, right? And that's where these drugs work, then they're going to start diminishing in terms of their effect. And so over a period of time, then those beta cells are going to be diminishing. And so the duration of the effectiveness of those drugs also decreases. So I hope that answers your question. I don't use it in my practice, correct. We're lucky that we have different options for the patients at the very least. We use copay cards for some of these brand name products for our patients. And, I work in a system that is very friendly to our patients. So the long-acting assembly, correct. Good. And let's see. I think I don't have any more questions. So what other questions do you have? Oh, 2 questions. You want to tell me what they are?
How long do patients have to be on Mounjaro to see weight loss?
Okay, so how long do patients have to be on Mounjaro to see weight loss? So the data that I showed you, it was over 40 weeks. Okay, but I think you can see some weight loss within weeks after starting it. Okay, I don't know exactly how soon. I know I saw a patient recently that said, I've been on, it was Trulicity. I've been on this for a long time and my diabetes is better, but my weight isn't. And the way I tried to explain to her is that this drug, you're not as hungry, but if you think about what you're eating, you're still eating the same thing, maybe just less of it, so it's still calorie dense food. So we need to make sure that patients understand that, it's not a magical drug, right? We still need to make sure that we exercise and that we eat healthy, have good choices. But the studies were over 40 weeks. And then next question.
The next question is, does increasing the dose of Mounjaro apply for both type 2 diabetes and weight loss?
Does the increasing dose of Mounjaro apply for both the diabetes and the weight loss? And I believe the answer is yes. Okay, so if you don't get to an A1C goal of less than 7 or less than 8, whatever you want, then you're still not at the maximum dose. And I believe if I would to go back on the slides for the Mounjaro, you'll see that the A1C was increased. It said as you increase the dose, so does the effectiveness. And the same thing with the weight loss. As you increase the dose of the Mounjaro, the weight loss is higher or greater. Good question. Other questions?
So what was the reasoning behind not checking sugars? Do they say not on daily basis?
So the question is, why did they suggest that we don't have to check glucose, home glucose values in patients that are not on insulin? Okay, they say it's of limited clinical benefit, right? So if I have a patient on an SGLT2 inhibitor, on metformin, if they tell me whatever their sugars are, I'm not going to make any changes on that. I'm going to wait till that maybe a couple of months, maybe the 3 months, and then check an A1C. I probably would not adjust the numbers there. I would look at potentially if the A1C is 12 and I just put them on metformin, that's not going to get them to goal, right? So, but in terms of basically, they said limited clinical benefit.
Yeah, and I think that makes
Right. Right. So I just want to clarify that they suggested it's of limited clinical benefit, but for some patients, it might provide insight. So that's what you're suggesting, that for some of your patients, they like to check it. You want to get that data. And I think they give us permission to do either one. So you're not wrong if you say no, you're not wrong if you say yes. So again, shared decision-making and patient-centered care. Question. Yeah, so she's suggesting that there is some data that knowing your glucose values drives behavior change. And I think we'll see this a lot, especially with the CGMs, right? The continuous glucose monitors. And I think some of that data shows that, you know, even if I'm not, if I don't have diabetes, if I have pre-diabetes, I'm not on insulin, I'm not on medications, I use that, I see it, oh my gosh, I ate that cake, it jumped up. Maybe I shouldn't do that anymore. So it drives behavior change. So I think that those have a good benefit. Yes, sir.
What I would say is, my recommendations that don't, burn money in some of it. I used to tell them, you can have them with monitor. I like to do,
So for those of you online, he's suggesting that if his patients are sick, they should probably check, or if he wants to check for effectiveness of the medication, or the other time was, they just want to. Yeah. Yes, so before I adjust the insulin dose, I ask the patient to check their glucose, and they're like, no, my fingers hurt. And I said, I don't need it every day. Can we do 3 times a week? They're like, okay, that's fine. And if 3 times is too much, well, how about twice a week? Whatever we can kind of compromise on. Okay. And again, it's more for their safety, right? Because you want to adjust the dose of insulin safely. All right, other questions? Does Carolyn cover the SGLT2 inhibitors? And I can answer that, yes. Yes. And Dr. Modi Bailey is sharing with us that it's mainly because we get 340B pricing. And so that is true. And so we are lucky in that way that we can do that for our patients. And we get a discounted price from the government for these drugs. And so that is exactly correct, Dr. Modi Bailey. Yes, sir. So she's just sharing that, I see your hand. She's just sharing that they charge us pennies or dollars for Ozempic. And that's true for the lower doses of 0.25 and 0.5 milligrams. But once it gets to the 1 milligram and 2 milligrams, then it's still the same price. But that's correct. Yes, sir. So the question is, do beta cells ever regenerate at all? And so I think the answer is yes, but I don't know for sure. I don't usually read that literature, but some of the studies I have read is that they can. Some of the drugs can help regenerate, but I don't know for sure in terms of, you know, if I can answer that very confidently. Unless, does anyone else know that information? Other questions? Other patients what?
All the patients wish that it would.
Other patients wish that they would, yes. We do too, Dr. Nato says. All right, well, thank you guys for participating. I'm glad to work.
Thank you very much. Thank you very much for that. So people, I can find and see the agenda, report from officers, I don't think that we have anything before today. There's no new business to discuss.